So very good evening to all of you. So welcome to this 31st online teaching class under the banner of Up-Aroi. Today is the second class for cervical malignancy. We have already covered CNS malignancy, head neck malignancy, and breast malignancy. And I hope that these classes must be very beneficial for our students and for our faculties also. So for this session, I would like to invite Dr. Rashi for the moderation. She is the Chief Consultant, Mexico Specialty Hospital, Vaishali. Dr. Rashi, it is over to you.
Thank you so much, ma'am. So for this important session of customer service, I would like to invite Dr. Bhavana Rai. Madam is a professor in radiation and oncology in PGI Chandigarh. And you know, when you will search for many papers in brachytherapy, Dr. Bhavana's name you will actually get very frequently. And she is doing so many, I think, Bhavana ma'am, you are doing many international researches of, in PGI Chandigarh. And yeah. I request you, please let us know about that Imrt trial. I think PGI Chandigarh and you is one of the part, Imrt for Imrt trial.
Yeah, we are part of all the Embrace studies as of now.
Yeah, so thank you so much, ma'am. And I hope our students will get benefit from you. Thank you so much, ma'am. Over to you, ma'am.
Thank you, Rashi. And I think congratulations, Up-Aroi for Aroi, not Con, for consistently doing these classes. I think it's really commendable. And congratulations to all of you for keep the flag on. So I will start with the class right away. Okay, so what I have learned is that you people already have had a class on the staging by Dr. Patanjali in the last session. So I'll straight away be moving on to the management of cervical cancer, and this will only include the treatment part. So you are familiar with the FIGO 2018 staging, and we'll be going by stage-wise for the management. So we all know that stage 1A is basically microscopic disease that is confined to the cervix. And for A1, it's the disease which is not invaded the basement membrane more than 5 mm. So the treatment is basically divided into if the fertility is desired or if the fertility is not desired. So if there is a young patient, since it's a microscopic disease, it's a very small microscopic disease, conization alone is sufficient, provided the margins of the cone are negative and there is no invasion of the membrane. And if fertility is not desired, if the patient has already completed the family, then the option is to go in for an extrafacial hysterectomy, that is type 1 hysterectomy, where you do not need to go very laterally. Okay, this is only because the disease is microscopic and it is confined to the cervix. The other option that is not a very common option is radiation. It is an option to surgery. It is not very commonly used. It is used only and only there is an absolute contraindication to surgery, which is seldom the case these days. So intracavitary brachytherapy alone in stage 1A1 is sufficient. And historically, some studies have shown that 65 to 75 gray at point A in 1 or 2 insertions, that is divided in 1 or 2 insertions, is enough to sterilize this disease. And in a study by Hamburger et al., there were no reported failures in 41 patients who were treated with brachytherapy alone. But for today's date, we do not have any studies of radiation only for stage 1A1 because of the surgical treatments that are well established. Now, once it is stage 1A1 with LVI and 1A2, so why does LVSI change the management? That is because once there is lymphovascular invasion, the risk of lymph node metastasis straight away increases to more than 5%. And the moment the risk of lymph node metastasis increases, that means simple hysterectomy itself is not enough. Means that you have to go in for lymph node dissection. So again, since it is confined to the cervix 1A1 and with LVI in 1A2, the choice of treatment again remains surgery. And like I said before, if fertility is desired, it is conization with extraperitoneal or laparoscopic pelvic lymphadenectomy. So the important thing to remember here for the postgraduates is that once you have an LVI, that is an independent factor for risk of lymph nodal metastasis, and hence the pelvic lymph nodes have to be addressed. The other option in these cases is vaginal tracheolectomy and laparoscopic lymph node dissection. This is done in select few cases where fertility is desired, where part of the disease along with parametrium is removed and the lymph nodes are can be removed. So this can be done in such cases. Now, if fertility is not desired, then the option is modified radical hysterectomy with pelvic lymph node dissection. So that means we move straight away from type 1 to type 2 hysterectomy, and you have to address the pelvic lymph nodes. Now, like I showed you before, if a patient is absolutely medically unfit to undergo surgery, then the treatment becomes intracavity brachytherapy. But here you have to add external beam radiotherapy again, because you have to address the lymph nodes. So your target volume or the area where risk of disease or the CTV becomes your pelvic nodes, and hence the whole pelvis has to be addressed. Now, coming to stage 1B1 to 2A. So we know that stage 1B onwards is anything which is more than stage 1A2, but disease that is still confined to cervix, which is macroscopic disease. And 2A is disease which has involved the upper vagina. Now, should the treatment of choice be radiation or surgery? Now here, both radical surgery, that is, this is an area where both have equivocal results. So both radical surgery, that is radical hysterectomy, with addressal of lymph nodes, that is pelvic and para-aortic lymph node dissection, or pelvic lymph node dissection with para-aortic sampling, and radiotherapy are found to be equally efficacious. So you could use either of the modalities. So what are the advantages of surgery, or how do you choose your patients for surgery or for radiation? Now, the advantage of radical surgery is that it provides an insight into adverse pathological findings. So you have a pathological detail of the patient. It also helps you to tailor the adjuvant treatment. For younger patients, the advantage of radical surgery includes that you can do ovarian transposition, patients who are desirous of, I would not say fertility, but of desirous of conserving their hormonal function. So ovarian transposition is an option because for squamous cell carcinomas, you must remember the risk of metastasis to ovary is extremely low. It is less than 1%. So ovarian transposition can be done, and it also offers a better sexual function. Because this again is debatable, because you do resect a segment of the vaginal cuff, although the vaginal length does reduce, but as compared to radiotherapy, there is less of radiotherapy related effects on the vagina, which is now a very much organ of interest. And hence, as compared to radiation, there is better sexual functioning in these patients. So going by these factors, considering these factors, you have to take a call whether the patient should go in for surgery or for radiation. However, one thing that you have to keep in mind is that despite surgery, there may be a significant number of patients who would require post-op radiotherapy. And once you combine two modalities of treatment, you do increase your control rates, but you also increase the complications. And this is something which we do not want in these early stage patients. And we know that in our setup, in a country like ours, there are a lot of patients who undergo inadvertent surgeries outside. They're incomplete surgery, so that should be discouraged. So your choice of choosing the modality has to be very careful. Now, what about radiation? What is the evidence that we have for use of surgery vis-a-vis radiotherapy in these group of patients? Now, this is the famous Landoni trial, which was conducted in 1999, and then there was an update analysis in 2017. What they did was that they randomized patients of stage 1B and 2A of tumor size more than 4 centimeters and less than 4 centimeters to EBRT and surgery. And I mean, it was the same for both these tumors. Okay. So what you saw was that the 5-year actuarial rate was comparable for patients, whether they were less than 4 centimeters or more than 4 centimeters for stage 1B to 2A. So they came up with this, that this was comparable. But what this study showed was, both the analysis combined, that half of the patients with tumors less than 4 centimeters, that is half of the patients in this subgroup, went on to receive adjuvant radiation, and 84% of patients with stage 1B2 with more than 4 centimeters received adjuvant radiation, meaning that a large number of patients actually required a dual modality of treatment. So that is why you need to read the papers carefully. And although survival was comparable, but factually, majority of the patients did receive adjuvant radiation. Also, when they saw, there was decreased complication in patients who received radiotherapy alone. That means patient who received surgery followed by post-op RT had an increased complication rate. There was a better DFS, better OS with radiotherapy in patients who underwent cellular radiation for recurrence, after there was recurrence. So what this trial recommended that was that primary surgery to the patients is beneficial in tumors less than 3 centimeters. The 3 centimeters came from the update analysis to minimize the risk of adjuvant radiotherapy. Another interesting thing that the study showed was that as compared to squamous cell carcinomas, it is the adenocarcinomas who have a better outcome and better overall survival with addition of post-op, with surgery and post-op radiation. So if there is an adenocarcinoma, naturally we tend to prefer to go in for surgery for these patients. And this has been shown by the updated analysis of Landoni trial. Although the evidence is not very, very robust and has not been able to be reproduced in other trials, that is primarily because adenocarcinomas constitute a small subgroup, or they are relatively uncommon, or less than about 10% of the total pathology of cervical cancers that we see. Now, once you know that you have to do either surgery or radiation, now how do you choose your patients for post-op adjuvant radiation after or post-op adjuvant treatment after surgery? Now, do you give adjuvant pelvic RT or do you give adjuvant pelvic chemo RT? So this again was addressed into randomized trials. So there was this trial of GOG92, which is the famous SEDLIS trial, and also a trial by Rotman. What they did was that they gave post-op adjuvant radiation to patients with high risk. And what they deemed high risk was the factors that they deemed was the tumor size, the stromal invasion, and the lymphovascular LVSI. So what they saw in this study was that patients, 13% patients had local failures who received RT versus 19% observation alone. And what the updated analysis showed was that there was 30% improvement in overall survival by addition of radiation, although the toxicity with radiotherapy was increased. And as compared to adenocarcinomas, adenocarcinomas showed a better effect with adjuvant radiation compared to the observation alone. So this trial definitely showed us that there was a subgroup category where high-risk features if they were present, post-op radiation did help in improvement of overall survival. And at the same time, it was the adenocarcinomas which showed the maximum benefit, but it added on to the toxicity. Now, are there any cases which require adjuvant concurrent chemoradiation with pelvic radiation? Again, they did take some criteria of positive pelvic lymph nodes, parametrial involvement, and surgical margins. And what they saw was that the addition of CT-RT to RT alone resulted in an 80% PFS as compared to 63 with RT alone. And similarly, the OS was also improved in patients who received CT-RT as compared to RT. Now, if you look at the trial above, what you would see was that there wasn't much difference that could be brought out in these studies. But however, once we added chemo-RT to a high-risk group, there was a definite benefit in terms of overall survival and PFS. So coming to or summing up the indications for adjuvant radiation based on these trials, you have to look for, they are categorized into high-risk features, intermediate risk features, and low-risk features. Now, the way I ask our residents to remember is, the very simple way of remembering the high-risk features is, this is the Peters criteria, that is the triple P. Always remember, it's positive para, positive lymph nodes, and a positive margin. So remember the 3 Ps. And if you have any one of the P, that is any single feature, this warrants the use of adjuvant chemoradiation. Okay, this was as we showed you in the previous study. Now, you have to also look at the intermediate risk factors, and the intermediate risk factors are the LVI, the tumor size that has to be more than 4 centimeters, and the deep stromal invasion to more than 1/3. Some prefer to take it 50%, but according to the GOG trial, it is 1/3. So again, you could also remember it by LLL, that is LVI, large tumor, and a stromal invasion. And for intermediate risk features, you have to have 2 or more features for a patient to qualify to receive adjuvant radiation. So this is adjuvant radiation alone. So if there are 2 or more intermediate risk factors present, the patient should receive receive adjuvant radiation alone. Now, if there are none of the above mentioned features, no adjuvant treatment is required. And although this does not mention adenocarcinomas, we also do include adenocarcinomas as an independent intermediate risk criteria for adding post-op adjuvant radiation. So if you have to give radiotherapy, whether it is post-op, if in a post-op setting, we give 45 to 50 gray at a dose of 1.8 to 2 gray per fraction over 4 to 5 weeks to the whole pelvis, with or without concurrent cisplatin if indicated, that is if it is a high risk or an intermediate risk, plus Walt RT. Now Walt RT is given to a dose of 6 gray HTR in 2 fractions, which is prescribed at 5 mm from the surface of the Walt, and this is given 1 week apart. Now you needn't give Walt RT to all patients. Patients who have high risk features are the ones where again you need to combine external radiation with Walt RT. Okay, so all the high risk features, or that is the triple Ps, the poorly differentiated tumors, or if there is a closed resection margin, a closed vaginal resection margin, these are the patients where you should combine Walt RT with external radiation. If other than these factors, you are giving pelvic radiation only for intermediate risk factors, then you can only do away with pelvic RT. Okay, because again, the more modalities you add on to the toxicities. So what do we conclude from these trials? We conclude that surgery is usually not an option. According to the Landry trial, you have to have a very careful patient selection. Majority of the patients require post-op RT, and this increased tumor-related toxicity, and tumors of less than 3 centimeters may benefit from surgery alone. So your choice or selection of patients to go in for surgery or radiation should be based on the fact that you should avoid dual modality as far as possible. And these days, a workup of an MRI does help us in assessing the risk factors. Now coming to stage 1B, 2, and 2B. So just a minute, I think. Yeah. Okay, so the other option is, did I miss something? Okay, I think I missed this slide. Okay. So once after the management of stage 1A2, 1B1, and 1A1, we come to the management of 1B2, B3, and 2A cervical cancers. So we know that in the new staging, there has been a 1B3, and 1B2 is now a tumor which is between 2 to 4 centimeters, and anything more than that is 1B3. And from the previous trials, we've seen that size of the tumor is an independent risk factor. It's an independent intermediate risk factors. So you have to be very careful about your selection of the treatment modality. Now, in this context, what are the options of treatment that you have? Can it be surgery alone? There are people who advocate the use of neoadjuvant chemotherapy followed by surgery, or is it concurrent chemoradiation plus brachytherapy? So in this context, surgery alone is not an option, and we have already discussed this, why it is so. Now, should neoadjuvant chemotherapy followed by surgery be an option? I know of this practice being going on in many centers, even in peripheral centers where private practitioners or surgeons prefer to give neoadjuvant chemotherapy followed by surgery because they think that it is an easier way of managing the patient and the patient remains with them. So what is the rationale of doing that? And there have been trials for the same. The rationale is that you reduce the need for post-op radiation and improve outcomes. However, this is a questionable rationale because you are adding another cytotoxic modality, and also reduction in the rate of nodal metastasis and parametrial infiltration. This was brought out in the meta-analysis, that is the Concurrent database review, which was in 2012, but this had its own flaws. So the counter arguments that are against the use of neoadjuvant chemotherapy include chemotherapy toxicity. We know it's a systemic form of treatment. By giving chemotherapy, you delay the primary treatment. That is, the primary treatment is either surgery or radiation. And although you may see a few responses, there are people who advocate and who swear that there is a response with chemotherapy, which is true. But then if you remember, there is accelerated repopulation of the remaining clonogens, And this offsets the efficacy of radiotherapy. So once there are resistant clonogens, your radiation becomes less effective. And of course, this offsets the benefit of the chemotherapy. And this leads to these potential disadvantages do lead to poorer survival outcomes. So please do not give in to the argument, either if it is with the surgeons or with the medical oncologists, for favoring neoadjuvant chemotherapy in this subgroup of patients. So how do we come to the evidence? Now, this is again the phase 3 evidence, which was published by Tata Memorial Hospital by Dr. Gupta. And there is also an abstract published in 2019. Now, what we saw was that as compared to surgery and neoadjuvant, followed by neoadjuvant chemo followed by surgery, compared to chemo-RT, patients who with chemo-RT had a better outcome. They had better pelvic control and DFS. Again, like we saw in Landoni's trial, about 1/4 of patients in the surgery arm, the neoadjuvant chemo followed by surgery arm, required post-op adjuvant RT or chemo-RT, meaning that about 1/4 patients underwent a triple modality of treatment, which again did result in significant toxicity. And as we can see, about 1/4 patients did have significant toxicity with neoadjuvant chemotherapy. Again, 20% in the surgical arm required to be crossed over to CTRT because they were not suitable for surgery after neoadjuvant chemotherapy. So whereas 1/4 patients required adjuvant treatment, 1/5 patients after neoadjuvant chemotherapy had to be crossed over. Okay, so the maximum benefit of chemoradiation was seen in stage 2B disease. So this trial clearly brought out that there wasn't a role of neoadjuvant chemotherapy, especially in stage 2B disease. And we are now still in a dilemma between stage 1B2 because the surgeons like to take it for themselves. However, you do have to have points of argument strongly favoring the best modality of treatment in the best interest of patients, ensuring that there is minimum toxicity for the patient. And quality of life and long-term toxicities are important to decide this optimal treatment. So as of today, we do say that chemo-RT is the standard of treatment for 1B2s, definitely for 1B3, that is tumor which is more than 4 centimeters, and 2B. Now, coming to the role of radiotherapy, radical EBRT with concurrent chemotherapy, that is concurrent cisplatin 40 milligram per meter square, given weekly for at least 4 to 5 cycles. These days, the evidence says it should be 5 weekly cycles, followed with brachytherapy, is the standard of care. Okay, so this delivers a good local control and delivers good tumoricidal doses. The benefit is that it results in organ preservation. It is a time-tested modality. We have a lot of evidence favoring the use of concurrent chemoradiation followed by brachytherapy. And now we also have the data from the Embrace, which shows us more than 90% local controls across all stages with the use of concurrent chemoradiation and image-guided brachytherapy. So the combined tumoricidal dose to high-risk volume after EBRT should be more than 85 Ray. Earlier, we used to say 80 to 85 Ray to 0.8, but with the advent of image-guided brachytherapy, we now talk in terms of the high-risk volume. So this has to be divided. Out of this 85 Ray, 45 to 50 Gray comes from EBRT, and the rest of 2 Gray equivalent dose given in high dose rate fractions comes from brachytherapy. Okay. So what is the evidence for concurrent chemoradiotherapy in cervical cancer? We said that is the standard of care. This came basically after an NCI alert in 2019. And the rationale for use of concurrent chemotherapy is that it improves the survival because it increases the local control. It causes radiosensitization. And once there is increase in local control, of course, the risk of distant metastasis decreases. It also independently helps in decreasing the rate of distant metastasis because it has a direct anti-tumor effect for micrometastasis and indirect effect on the future metastasis by preventing cervical tumor recurrence. Now, I will not go to the details of these trials, but for you to remember, there were 6 trials which on which the basis of which this NCI alert came, and all these trials favored the use of concurrent chemoradiation. But what you really need to focus on is this one trial, which was the only trial which compared radiation chemo-RT to a standard RT alone arm. All the rest of these trials either compared it to surgery or to extended field radiotherapy or to a different form of chemotherapy with radiotherapy. So this was this initial trial by Parser et al., which was the NCI Canadian trial, which questioned the role of concurrent chemoradiotherapy. And this trial was the negative trial. And they did not observe any difference in the PFS or overall survival. And the risk for lack of benefit in this trial was again attributed to the lack of surgical staging, to a small sample size, and to a confounded factor of anemia in the chemoradiotherapy arm, which they said led to resistance and poorer outcomes and omission of 5-FU. So the final conclusion that we are told was, the authors were made to conclude, was that despite this negative trial, the evidence favored the use of concurrent chemoradiation. So there have been various meta-analyses, and of this recent analysis by Whale published in 2008, this compiled 5 randomized trials. What this showed was that there was an absolute benefit of DFS of about 8%. And if we looked across stages, and there was an overall survival benefit of 6%. And if we looked across stages, the maximum benefit was seen in locally confined bulky disease, that is the 1Bs and the stage 2s. Now, for stage 2B, it was 7%, and it was the minimal for stage 3 and stage 4, that was 3%. So there was a 19% absolute overall survival benefit. However, after this, there has been another randomized trial from the Tata Memorial Hospital, which is the CRACS trial, which evaluated the benefit of concurrent chemoradiation in stage 3B disease. And that trial has also shown that there is a DFS benefit of 9% and overall survival benefit of 8%, meaning that concurrent chemoradiation does improve, result in improvement of DFS to the tune of 8 to 9% across all stages of cervical cancer. So are the number of concurrent cisplatin cycles important? Yes, the EMBRACE study also shows this, and there is another trial from the ICMR which shows that total dose of 40 milligram per meter square given once a week for 5 to 6 cycles is what gives the maximum benefit of concurrent chemoradiation. And if you talk about the cumulative doses, it has to be more than 150 milligram of cisplatin that has to be given for us to reap the benefit of the concurrent chemoradiation. And this dose given in 5 to 6 cycles has not only an impact on the local control, but it has an impact on the systemic control, especially in high-risk patients, that is the node positive or stage 3, stage 4 patient, with a 20% difference in systemic recurrence. So that is the amount of difference that adding concurrent cisplatin does to radiotherapy. Now, what are the management options for stage 3 disease? We know that stage 3 disease is basically the disease that has spread to the parametria, to the lower vagina, or to the nodal. Now, we know for the vaginal disease, all you have to do is increase your portals down to include the vaginal disease, giving a 2 centimeter minimum margin. For the residual parametrial disease, what you do is, after you've given the pelvic EBRT, you can give brachytherapy, and I will be covering brachytherapy in the next class. So if you have a residual disease after EBRT, if the disease is confined only medially, or there is minimum involvement of the parametria, and intracavity alone after external beam radiotherapy suffices in most of the cases. If there is extension of parametria to the medial third, or maybe 1 to 1.5 centimeters laterally, then you have to have something more than intracavity, and this is where we add the needles along with an intracavity interstitial. This is given with the combined ICIS applicators, that is the Vihana applicator, the Aros, or the Venezia applicators. And if you have a heavy parametrial involvement, which is extending to the lateral parametria, these are the tumors which are tricky to treat because it is very difficult to get the doses to the lateral parametrium, and these tumors can be treated after EBRT with either an ICIS approach or with a pure template-based interstitial brachytherapy. The other option of managing parametria is that you give an external parametrial boost along with the brachytherapy. That is, you either by the time you are waiting for the brachytherapy, you could give an external parametrial boost, and this is given as an additional 10 gray. You can give it either as an ABPA portal or as a conformal boost. With increasing conformal EBRT techniques that we are using, we prefer usually to give a conformal boost. In the olden days, we were using a midline shielding, which was a 4 centimeter rectangular block of 5 HBL. So for centers which are still sticking or using conventional radiotherapy techniques, you could give an external parametria boost with an APPA portal, giving a midline shield of 4 centimeter, a 5 HBL shield of 4 centimeter. Now, the third option, which is not a very welcome option, is giving external pelvic boost, that is supplementary RT. That is for a patient who is an absolute contraindication to brachytherapy of any form. You supplement with external radiation, but this definitely leads to poorer outcomes and does lead to increased toxicity because you're irradiating large volumes of the pelvis. Now, the other aspect of stage 3 is the nodal disease. We know that now the FIGO 2018 stage divides 3C into C1 and C2. And C1 is when there are pelvic lymph nodes involved, and C2 is when there are paraiotic lymph nodes involved. So we know that lymph node itself is a poor prognostic factor, and that is why it has been incorporated into the FIGO 2018 as a stage 3C disease. Now, according to the Embrace study and according to the studies that we've had before, the lymph node metastases are most commonly seen in the pelvic region, and about 90% metastases occur in the external and internal iliac region, about 30% in the common iliac, about 15% in the inguinal, and about 3% in the, 15% in the paraiotics, and about 3% in the inguinal lymph nodes. So, once the patient is diagnosed, about 50% patients do have lymph node involvement. And this we are seeing as we are using sectional imaging. There was a time when we were practicing radiotherapy as residents, because we were not doing CT scans for these patients, we were planning these patients with conventional radiation, we were not seeing many pelvic lymph node recurrences. And now that we do imaging for most of these patients, we see that about 50% patients of locally advanced tumors that present to us harbor pelvic lymph node metastasis. That means the stage is upstaged with stage 3C2. And if you see the distribution, 99% of these lymph nodes are confined to the pelvis. And what is important here to know is that half the patients who have paraiotic failure have a paraiotic confined failure. That means they do not fail in the pelvis. And the 5-year survival for patients with node positive disease decreases drastically as compared to node negative disease. So the Embrace study has shown us that patients who have node positive disease have a 5-year survival of 67% compared to 81% for those who have a node negative disease. We also have more information about distribution of paraiotic lymph nodes. Earlier, we used to take the portals of the paraiotic lymph nodes very high up, that is T12 to L1, L2 interspace, thinking, and we used to take a margin higher up, excuse me. But now we've seen that majority of these paraiotic lymph nodes are situated in the lower paraiotic region. And also, if we see the location of these lymph nodes, most of the lymph nodes are situated in the left side, that is, they are either in the left paraiotic region or they are in the iotocaval region. And isolated lymph node metastasis in the right paracaval region is extremely uncommon. And this distribution forms the basis of the paraiotic nodal contouring by Kinnan et al., which again, I think because of the time constraint, I will not be able to go into. So the management of nodal disease for nodes, the dose of 45 to 50 gray to the whole pelvis does not suffice. So the nodal disease requires a higher dose. So how do you give a higher dose with EPRT? The dose that you require for sterilizing these lymph nodes is to the tune of 60 to 65 gray. Now, these days, because again, we have conventional techniques, we do treat the paraiotic lymph nodes very commonly. And the techniques that we use for treating these lymph nodes are, the most common is the SIB IMRT, where we give a higher dose, we SIB with a higher dose to the involved lymph nodes. And this gives us the benefit of dose escalation. At the same time, we can spare the normal tissues, that is the bowel, bone marrow, and the kidneys. So we typically give a dose of 2.4 to 2.2 to 2.4 to 2.5 gray per fraction, and in 20 fraction. So the dose fractionation that we follow for SIB-IMRT is 45 gray to the pelvis, that is 1.8 gray fraction to the whole pelvis, and to the involved lymph nodes, that is either it's the pelvic or the paraortics, we give a dose of 55 gray in 25 fractions. We do try and go up to 60 gray if the bowels are spared, especially in the paraortic region. The other way that you could address these lymph nodes is, if you do not have provision for doing a SIB-IMRT, is a sequential nodal boost. That is, like we did a sequential parametrial boost, you could do a sequential nodal boost, which could be a conformal boost if possible. Now, coming to the radiotherapy techniques, they can be broadly divided into conventional, 3D conformal, and IMRT, that is IMRT with image-guided radiotherapy. Now, what is the target volume for pelvic radiotherapy in cervical cancer? We know we have the CTV tumor, and this CTV tumor comprises of the local disease, that is a primary tumor, which is clinically and radiologically visualized, because these days we are using more and more imaging. And along with this, we have to include the whole uterine corpus, the cervix, the upper third of the vagina, and parametrium. Now, if there is a vaginal extension, then we take at least a margin. The distal margin is at least 2 centimeters distal to the vaginal extension. Now, for the nodal CTV, we have to go up to the bifurcation of the aorta, and we have to include the common iliacs, external iliacs, internal iliacs, obturators, and the presacrals. And paraortics are included if it's a stage 3C2 disease, that is, if the paraortic lymph nodes are involved, and inguinal lymph nodes are included if there is lower third of vaginal involvement. As far as the evidence is concerned, till date, there is no evidence of using prophylactic paraortic radiation, although this is being studied in the trials. Now, I'm sure you're all familiar with the conventional simulator marking. The superior border is at L4, L5, and this was kept presuming that it covered the common iliac lymph nodes, and the lateral margin is kept at 1.5 to 2 centimeters from the widest pelvic brim. And the lower border is at either obturator foramen or 2 centimeters below the lowermost point of involvement. Now, the lateral fields are the same as APPF fields, and the anterior field is kept at the anterior edge of the pubic symphysis. This again is kept so as to include the external iliacs, which may at times bulge out. So you have to ensure that you are including the external iliac chain. And the posterior border encompasses the sacral hollow in all cases, and only in very early stages does it go to S2, S3. Now, there are a lot of advantages of two-dimensional therapy. It again has been time tested, and we did have very good results using conventional therapy, and it is based on bony landmarks. So it's very simple to mark. It's a convenient planning. It does not require sophisticated EBRT machines, and this results in good local control. Now, the offside of this is that because you are including large volumes of normal tissue, there is increased toxicity. There are higher chances of a geographical miss because you are going only by bony landmarks, and it does not take into account the individual patient anatomy. So in this context, there have been, again, studies. This was a study from PGI and another study from MD Anderson, when they saw that using conventional techniques, there is a component of geographical miss in about 75% patients, and 90% of this miss occurs at the superior border. That is at L4, L5 border, because that is the area where common iliac does not bifurcate in most of the cases. And if they correlated this to the clinical outcomes, there were 55 to 95% of field recurrences occurred above the superior border, and that depended on the nodal positivity in the pelvis. So what we can conclude is that most regional recurrences after definitive RT include a component of margin failure, and this is usually to the superior border. And the other border where the failure occurs is this posterior border, which is kept at S2, S3, and this, as a result of this, you could be missing, if you see this picture, you could be missing either a part of the cervix in a few patients, and you could also be missing a group of presacral lymph nodes. So these days, practically for all the locally advanced cervical cancers, that is 1B, 2 and above, we do include the sacral hollow. Now, coming to three-dimensional conformal pelvic RT, this ensures adequate target coverage. It enables individualizing treatment fields, because you know where your aortic bifurcations are, whether you are missing the external iliac. So you can tailor the fields according to the patient's anatomy. There is reduced toxicity when compared to conventional techniques. Again, 3D CRT facilities are available now in most of the centers. It is a cost-effective technique compared to the advanced techniques of IMRT and IGRT, and this results in good local regional control with accepted normal tissue toxicity. Again, we did show this in one of our retrospective series published in the Japanese Journal of Clinical Oncology. So till date, 3D CRT is the standard of care in intact cervical cancer, that is in definitive cervical cancer. Okay. Now, coming to the role of IMRT in cervical cancer, the benefits of IMRT that could be, that is, there is a decrease of bowel and hematological toxicity, particularly in post-op cases, because we know that once the uterus has been removed, the entire bowel tends to fall into the pelvis, and it is unavoidable, and bowel toxicity becomes kind of inevitable if you just perform a conventional technique, or if you just treat the patient with the conventional techniques. IMRT also gives an opportunity for dose escalation, especially in patients who have lymph node involvement. So whether it is pelvic or para-aortic lymph nodes, you can sit these lymph nodes and escalate the dose to 60 to 65 gray. And of course, when we need to use extended field radiation. However, again, there are a lot of limitations of IMRT. We note that the evidence in definitive setting, I would say definitive, that is in intact cervical cancer, is still evolving. What is the extent of improvement and at what risk is something that we need to see, because once you're doing IMRT, we know that there are a lot of complexities involved in intact cervical cancer and in the pelvis. And the uncertainties that occur are that there is a constant organ motion. There is an inter and intrafraction motion which is going on. The bowel is constantly moving, the bladder is filling, that there is rectal filling and emptying, there is expansion because of the gas. So this is a dynamic motion which is going on in the pelvis. So, and this requires a very accurate target delineation also. And once you're using IMRT, you do reduce the margins, and there could be a chance of a geographical miss also. So you have to be very sure about using IMRT, and you have to keep into consideration what is the improvement. And then the most important thing is it is very labor intensive, and in high volume centers like ours, which most of the people deal with, is it really worth the expense and the effort? Especially when we know that in an intact cervical cancer or in a definitive settings, we do have equivalent results as of now. Now, coming to the evidence for the role of IMRT in intact cervical cancer, this was a study published by Gandhi et al. In 2013 from AIIMS, and they showed that there were comparable local control and survival outcomes. There were fewer grade 2 acute GI toxicities and the grade 2 and 3 GI toxicities. However, this study was statistically unpowered, and they compared it to a conventional arm where 2D brachytherapy planning was done. And in today's era, what we treat as a standard is a 3D CRT and image-guided brachytherapy. So in this context, the results of these studies, this study really needs to be taken or studied carefully. So we do have another phase 2 trial, that is the INTERTECH 2, published in 2017, and we also have the results of the INTERTECH trial, which have already come. Now, what they have shown us that IMRT does reduce the acute hematological and GI toxicity compared with the standard treatment. But again, this is phase 2 evidence. So as of today, we do not have a robust level of evidence favoring IMRT in intact cervical cancer, although we very much await it. Now, what about IMRT in the post-op setting? We know that there is an increased toxicity. Now, in the post-op setting, we have two major trials that have come up very recently. One trial is the Parser Trial, and the other trial is the trial by the NRG, that is the Time-Seize trial. So this Time-Seize trial basically included patients which were primarily of endometrial carcinoma, and what they saw was that the IMRT did reduce acute GI effects, that is at 5 weeks of radiotherapy. It did reduce the acute urinary effects, urinary acute effects. Some late GI adverse effects, that is the diarrhea, was reduced at 1 year, and late urinary events were definitely reduced at 3 years with the use of IMRT. But what the study clearly demonstrated was that there was no difference in this disease outcomes. That means there was no difference in the local control at 2 years. Okay. Similarly, the Parser trial, which has again been recently published last year in the Journal of Clinical Oncology, again studied patients, compared patients of conventional 3D CRT with image-guided radiotherapy. This included a lot of patients who received concurrent chemoradiation, because this study included patients of cervical cancer and endometrial cancer. And what they showed was that 3-year grade 2 late GI toxicity was definitely about 50% less with the use of image-guided IMRT compared to 3D CRT. And not only GI toxicity, any grade 2 late toxicity was again about 20% less with IgIMRT compared to 3D CRT. There was reduced fatigue, diarrhea, loss of appetite, and bowel symptoms. There was no significant reduction in acute toxicity as shown in Time C trial. And again, there was no difference in local control or survival. So one very important message that we get from both these two level 1 evidence phase 3 studies in post-op setting is that IMRT definitely does not lead to improvement in local control or survival. What it does is that it reduces the toxicity, and that is the acute and the late GI toxicities. Now, coming to the role of adjuvant chemotherapy, the rationale behind this was that there could be a distal control, because we know that approximately 15 to 20% patients develop metastasis. Although we have been able to demonstrate more than 90% local controls, even the Embrace study shows that there is a substantial number of patients which develop distant metastasis. So that again continues to be a matter of concern. So in this context, the Outback trial was the one which studied the benefit of adjuvant paclitaxel and carboplatin after completion of concurrent chemoradiation and brachytherapy. And this trial was published in 2021. So what this again showed was, which was very strange and surprising, was that there was no survival. I mean, I wouldn't say strange, but it did come as a surprise that there was absolutely no survival benefit between the two arms. Now, patterns of again recurrence were similar in the two treatment groups. Even in the high-risk group, where we would have expected to have a benefit with the addition of chemotherapy, that is the group where there was node positivity, there was no benefit of addition of adjuvant chemotherapy. What adjuvant chemotherapy did was that it increased the grade 3 to grade 5 adverse events, which occurred significantly more in patients with Imrt, was to the tune of more than 20% more increase in toxicity seen in patients who went on to receive adjuvant chemotherapy. Quality of life was adverse with the use of adjuvant chemotherapy. So there was no survival benefit, there was increased toxicity, and it adversely affected the quality of life for 3 to 6 months, which normalized from 1 year onwards. So as far as the evidence for the use of adjuvant chemotherapy, even in advanced high-risk cases is concerned, we do have, again, level 1 evidence stating that there is absolutely no benefit of using adjuvant chemotherapy. The role of chemotherapy in cervical cancer still remains in the context of a concurrent chemoradiation, where we do have to add it with the radiotherapy. Now, summing up the treatment for cervical cancer. Now, if you have a limited disease, that is, if there is a disease of 1A, B1 to 2A, 2B, that is less than 4 centimeters, you have options for radiation or surgery, but the choice of treatment has to be unimodality. It has to be a carefully chosen patient, especially when you are dealing with this subgroup of 2As and 2Bs. This has to be done only after discussion in a tumor board. Okay. Once you go above this disease, that is, if there is a tumor size of more than 4 centimeters, that is 1B2 and above, then you have to again be very, very careful about selecting your patients for surgery, because majority of these patients will go in for post-op adjuvant radiation or chemoradiation, as demonstrated by the studies of the Landoni and Setlis. The other option, which is, or the treatment of choice, I would say, is radiotherapy with concurrent chemotherapy and brachytherapy. For disease that is 1B2, 3, stage 2 and above till 4A, the choice of treatment again is radiotherapy with concurrent chemotherapy and brachytherapy. So anything which is more than 4 centimeters, 1B2 and above, ideally it should be radiotherapy and concurrent chemotherapy with brachytherapy. And it's only a very select thought, that is 1B2 is the controversial area, where again you have to choose your patients carefully. So with this, I would end the class for today. And I would invite any questions or comments for the same.
Yeah, thank you so much, ma'am. It was interesting talk and you have presented it very well. And there are questions in our chat box. First question is from Dr. Pankaj. What would be the volume of presacral lymph nodes in stage 3C1? Is up to S2 or whole sacrum nodal volume?
Okay, Dr. Pankaj, I already, did say that in the talk, in the class, that you have to include the whole sacral hollow. Okay. So volume of pre-sacral lymph nodes, stage 3. So the entire sacral hollow has to be. Once you are contouring, then of course you contour, you contour the sacral strip, the pre-sacral strip, and then, where it ends is with the PTV margins is what you are doing if you're doing a conventional technique. If you're doing a conformal technique, if you're using a conventional technique, it has to be a complete sacral hollow. I hope I'm clear on that.
Yeah, thank you so much, ma'am. Another question is post EBRT by conventional 2D technique if patient is unfit for brachytherapy and is planned for supplement RT, is there any role of adding weekly chemotherapy while prescribing? Yeah.
No. See, basically, once we are planning a patient for supplementary RT, means that this patient is again a poor responder. Okay, this patient has not responded well. That is why you cannot even do brachytherapy for this patient. So your adding of chemotherapy is not going to give benefit. Something which has not given a benefit in 4.5 weeks or 5 weeks of treatment is unlikely to give benefit in the next 2 weeks of supplementary RT that you're going to be giving, and this will only add on to the toxicity. So these patients are anyways going to be falling in the poor prognostic group, and this is a modality which should be the last modality that should be used. So as far as possible, do try and use brachytherapy. So there's no role of adding weekly chemotherapy.
Ma'am, there are many questions.
No, I'll be glad to answer. That means, it's nice if there are questions. I'm glad there are questions.
What should be done if FNAC proven inguinal lymph node is present?
You have to include those lymph nodes.
And yeah, you have to include, and the dose should be radical dose up to 66.
See, it will again depend on the lymph nodes what is the size of the lymph nodes. If you have very small lymph nodes, then probably even 50 gray, you can reassess and see whether they are covered or not. And if there are larger lymph nodes, then of course you can do CBI-MRT. We do CBI-MRT for these patients. Anything that is more than 1.5 centimeters, we do CBI-MRT in inguinal region.
Thank you, ma'am. Another is there any cutoff of lateral paras to guided brachy, that is ICRT or interstitial?
Okay, so I'll be talking about this in the next class. There is a cutoff. See, the needles, if you use a combined intracavity interstitial approach, the needles only cover about 1 to 1.5 centimeters of the parametrium. So if you have a lateral parametrial extension or distal parametrial extension, you have to use either oblique needles, that is, you have to use the advanced applicators, that is the Venezia applicator, which has a provision for a straight and an oblique needle to reach to the lateral pelvic wall, or you use a template-based interstitial applicator, that is a Muppet or a Syed Nablet.
Dr. Rashi?
Yeah, I think
she has lost the
network. Yeah.
Yeah. So I will continue. Next question: we need not remove the ovaries during hysterectomy. Is it only for squamous?
Yes, it is only for squamous, because for adenocarcinomas, there is risk of ovarian metastasis, and it could be to the tune of about 5%. But when you're dealing with squamous cell carcinomas, that is the only case where you do offer ovarian transposition. In fact, if there's an adenocarcinoma, that's a contraindication for ovarian transposition. So because the risk of metastasis is less than 1% in squamous cell carcinomas, these are the patients who can be, where ovaries can be preserved.
Next question, ma'am. What is the lower extent of obturator node, CTV?
Lower extent of the obturator lymph nodes?
Yeah.
We follow the RTOG guidelines for contouring and the guidelines by Taylor et al. The lower extent of obturator lymph nodes, we basically, go up till the head of the acetabulum, where we see, and that is where we stop contouring.
Dr. Rashi, have you joined again?
Yeah, I've joined.
Yeah. So continue.
Yeah, sure. Yeah, do we include inguinal?
Sorry?
Do we
Sorry?
include inguinal nodes only if lower 1/3 vagina involved?
Only if
Then-
lower 1/3 vagina is involved. Then only we include, because then you have to extend your borders. You have to do the inguinal lymph node contouring. Okay. And then you have to bullion it and you know, once they asked me, okay, the question was the lower load of obturator node. Now this is basically once you enter the obturator foramen. Okay, so that is where that is the level which is going to correspond to the lower extent of the obturator lymph nodes. So between the obturator foramen and your inguinal lymph nodes, you have to bullion to ensure that there is a continuity when you're including inguinal lymph nodes.
Okay, ma'am. And another question is, in IMRT, what should be the superior extent of segmentation?
Superior extent of
Segmentation.
segmentation. You mean the extent of?
I don't know segmentation.
There is a question. I cannot.
Means contouring. Superior extent of contouring. Segmentation is jargon for contouring.
Yeah. The contouring will be basically dependent on the extent of nodal involvement. So if you are including the para-aortics, definitely the nodes go up to, you go to the level of the renal vessels, that is the renal vein. And if you are wanting to include only the pelvis, you go up to the aortic bifurcation. But yes, the EMBRACE study is now coming up with a risk categorization based on the small pelvis, big pelvic, and this thing. As of now, we are only dealing with standard pelvic fields, that is going up to the aortic bifurcation, or the para-aortic fields going up to the renal vein, or if the nodes are present higher up, then we take it to 2 centimeters higher to the topmost involvement or the proximal involvement of the lymph nodal chain.
Ma'am, another question, shouldn't we change upper border in conventional field as failure is more as per trial shown by you?
See, again, if you increase the borders, not every patient, how will you know where to keep the border? Because the aortic bifurcation varies, and you would just increase the volumes and increase the toxicity. So that is why, I mean, even if you're treating with conventional techniques, I think most of the patients do come with a CT scan or a sectional imaging. So that is where you could see the aortic bifurcation and, see where it corresponds to the bony landmark, and then mark it accordingly. But again, you have to keep in mind the volumes, because sometimes the aortic bifurcations could be as high as, mid L3 also we've seen. And then once you add the PTV, the fields become quite huge.
Yeah, thank you, ma'am. And the question that earlier was like, in post-op case, superior extents of CTV1.
Post-op case, superior extent of CTV1. Okay, that is the CTV tumor.
Okay, ma'am.
CTV1 is CTV tumor.
Yeah, I think so. CTV1.
Yes, because that would be the nodal CTV otherwise.
Yeah,
So, okay,
otherwise,
in post-op cases, the superior extent is going to be, because see, once we are talking about the CTV tumor, the superior extent comes from where the parametrium starts. So if you have a post-op case, you basically have to take an ITV margin above the vault. Okay, so this is based on the recent RTOG guidelines that have come up. Okay, so you see where the vault is ending, and you create an ITV with an empty bladder and a full bladder, or a standard ITV margin based on what the Taylor guidelines say. And from there, you take the fields laterally to the lateral pelvic wall and include whatever is there to the lateral pelvic wall. So that would be the superior border of your CTV1, that is the CTV tumor. If you're talking about your nodal CTV, the nodal CTV, according to the guidelines by Small et al., should be placed at L5S1, but that is provided your lymph nodes are pathologically negative. If you have pathologically positive lymph nodes, that is if you're dealing with a high risk case, then you would prefer to go up higher to the aortic bifurcation. That is the CTV2 or the CTV nodal. Is that
Okay.
clear? Or we
I
could probably
think,
ask the person who has asked the question if it's clear for that person. Where is the-
Mr. Avinash, actually, no, the person who is asking, you can actually open the mic so that it can be cleared.
We cannot do that over here because it is a webinar, so it is not possible right now.
Okay,
Okay.
okay, okay, fine. Okay, then
It's clear, actually, they have written. So if in stage 4A, if we are suspecting VVF, should we consider radical RT?
okay, if it's suspecting, meaning if the patient is symptomatic, see, there is stage 4A can be either, you can classify a patient of having stage 4A either on an MRI, where there is infiltration of the bladder wall, and usually we confirm it with a cystoscopy. But if there is infiltration of the bladder wall, it is not infiltrating through and through, we do take up these patients for, standard concurrent chemoradiation. I'm going to say, if there is a frank fistula, then the intention of treatment becomes palliative. That is, if it's a pathological fistula, the intention of treatment becomes palliative, and then we give the patients external radiation in dose per fraction of 2 gray, and we assess the patients every week. And then depending on how symptomatic the patient is for the fistula and how the response is, we take up the radiation gradually to 46 gray. If the disease is very huge and the intent of treatment is only palliative, we only go up to 20 gray in 10 fractions, and then call the patient again after 2 to 3 weeks for assessment of response. And if the fistula seems to be healing or controlled, there are occasions where we've added radiation thereafter. Otherwise, the intent is purely palliative. If
What
it's
is
a
the
surgical
dose?
fistula, sorry.
Yeah, ma'am, please continue. Sorry, please
What
continue.
is the dose? So like
Yeah,
I said,
another question. There was another question. And what should be the dose in your case? In VVF?
in VVF, like I said, we usually, plan the patients for 20 gray in 10 fractions, and we assess them every week. Okay, so if the patient is, if the fistula has, if the disease is small, sometimes with a centrally localized disease with not much of lateral pyramidal extension, occasionally the patients may have a fistula. So these patients, you can continue to treat them with radiation till about 46 gray. You can give pelvic radiation. Now, if the intent is purely palliative, that means there is a frozen pelvis, there is a fistula, you know that there isn't a curative potential for this patient, which will be the case in majority of cases, then the intent becomes palliative. Then you go in for 2 gray per fraction, 20 gray in 10 fractions. Then, because you are basically meant to palliate the pain, the bleeding. That is what you want to palliate, and the pressure symptom.
Exactly.
And after that, you reassess the patients 2 to 3 weeks to assess how much palliation has been achieved, and then decide accordingly whether you want to go in further treatment or not, depending on the response.
So, Dr. Bhavana, is there any role of a neoadjuvant chemotherapy in these cases?
There are, there isn't any trial of neoadjuvant chemotherapy in this setting, but if we see the National Cancer Grid guidelines, there are some centers which do give neoadjuvant chemotherapy for patients who have either very large lymph nodes, or patients who have impending fistulas or fistulas. But we at our center usually do not practice neoadjuvant chemotherapy in such patients. We do practice the only indication where we practice neoadjuvant chemotherapy is in stage 3 C2 disease, where if there are very large para-aortic lymph nodes where kidney sparing is not possible. So those are the cases where we would give chemotherapy about 3 to 4 cycles, assess for shrinkage of the lymph nodes, and then go it for radical para-aortic radiation and brachytherapy.
Okay, ma'am. Another question is, can we give IMRT boost to achieve total dose instead of ICRT?
No form of IMRT or SBRT is a substitute to ICRT. And this has again been clearly demonstrated in studies. There is evidence that there is about 20%, 25% fistula rate. There is an increased complication, and definitely this question should not be even asked. So there is no substitute to brachytherapy.
Yeah.
because the dose conformity and the dose that you can achieve with brachytherapy is impossible with any form of fancy external radiation techniques.
Yeah, any form of SBRT, SRT, anything.
No.
Yeah,
No.
actually, if you know, I think if PGs if they don't know how to do brachytherapy, they must learn.
It is absolutely essential.
It is absolutely essential. Another question is, does Dr. Shaleen, is there role of neoadjuvant chemotherapy when there is waiting list?
Sorry?
Is role of
Is
neoadjuvant
the role of?
chemotherapy role of NACT when
When
there
there is a long waiting list, especially in the government hospital where we are having the 3 to 4 months waiting list for radiation.
Sir is, you asked that question to sir, no?
All right.
Shaleen,
Oh,
sir, yeah.
Dr.
Hello, sir.
Bhavana,
Good to see you.
good to see you. I'm sorry I joined 10 minutes late, which was very embarrassing. I got stuck somewhere and I really wanted to join up front, but I have listened to most of it. I asked this question with a particular thing in mind. The typical story in most hospitals, including yours, would be that there is a wait list. And I know, and a lot of blunderbuss radiotherapy goes on, which clutters the waiting period. Patients with palliative intent get radical doses, they choke the system. So while it's a red line, my question is, this is a practice that people are following. And I just want to know if there is any trial that shows that there is a detriment in survival or there's a detrimental outcome with the use of chemotherapy upfront. Just wanted to know. This was my precise question. Is there anybody who's shown that? Because inevitably people are doing this. They're giving Taxol platin, platin, capecitabine, platin 5-FU for 2 or 3 cycles. The patient thinks some treatment is going on. While you buy time, a proportion fall off, and then they go on to receive telebrachy, etc.
So there is a trial, I do not remember it offhand, but there is a trial in locally advanced cervical cancer where there was a center which has given neoadjuvant chemotherapy in such cases. And even if we see the guidelines by ASCO, the ASCO guidelines for the LMICs, they also do mention that you can give neoadjuvant chemotherapy if radiation facilities are not present. Although this, this came a couple of years ago, but then having said that, we cannot consider it as a standard of care. The other thing that I did not mention, Rashi, in the palliative radiation, we do use a lot of palliative single fraction radiotherapy. Now, the patients where we use 20 grade 10 fractions are the patients where we are probably hoping that they may respond with a central small disease. But sorry, that didn't cross my mind. Single fraction is very widely practiced, and that is one way to declutter the system or declutter the waiting lists, is use a lot of hypofractionated palliative radiotherapy. So we typically do it on Saturdays, and we do know that we do have a substantial number of patients who do require palliative radiation. And we've done a trial in our setup only, and we will be presenting it in the Astro this year. This is again a randomized trial of 8 gray versus 30 gray in 10 fractions in palliative radiotherapy, where we analyze the quality of life and toxicity also, and there is no difference. So I think that is one way, rather than practicing neoadjuvant chemotherapy, that should be a last resort, although even ASCO is mentioning it these days. But I mean, we should look for other ways to declutter the system. And
but of course, you talked about the accelerated repopulation, which is staring you in the face, and that's something that people don't seem to accept. But this is good news. 8 gray single fraction versus 30 in 10, which means that particularly patients. So, for instance, we currently, when we're doing our rounds, etc., we find that somebody who has a bilateral PC and they say, no, let's give some chemotherapy and then try radiotherapy. I said, this is a frozen pelvis.
Exactly.
This is ridiculous.
And
this
what chemotherapy would be giving? Exactly.
Yeah, that's it.
Would be giving some form of platinum, and why?
Yeah, but we have to have the grandmaster talk about it. Because anybody else less than a grandmaster, nobody will believe. That's why I want to bring this up. This is happening all the time. Okay. Oh, okay, right. Somebody else has not at all.
My pet.
Lovely. He completely agrees your view. All right. So are we going ahead, Dr. Rashi and Dr. Ruby? Are we
Uh,
already stopped
yeah,
now? What do you suggest?
Hadi, 1 and 2 questions are there. Dr.
Please
Ashley
finish.
can
Please
pick up.
kindly finish.
Yeah, please. Any hypofascinated definitive artery regime?
No.
So ma'am, how do you deal with late complications, especially after 3D CRT?
Late complications after 3D CRT. See, majority of the complications occur because of brachytherapy, not the external radiotherapy. And it's the small bowel complications that are mainly with external radiation if you're using larger fields. But again, it's the brachy. And it depends on the grade of complications. With more and more usage of image-guided brachy, with image guidance, I don't mean MRI-guided brachy, I mean CT-guided brachytherapy, which we are doing, and reporting of 2 cc doses, we are seeing lesser late complications, and a complication rate is less than 10%, I would say less than 5%, that is what the reported is. But then again, it depends on the grade of complications. If you're categoric about a particular toxicity, that is how I can answer it. You want to know about hematuria, grade 3 rectal toxicity, what exactly do you want to know about?
Ma'am, another question is positive inguinal lymph node. It is a stage 4 metastatic disease. So intent should be definitive or palliative?
See, intent these days is definitive even in metastatic disease, where we talk about treating oligometastasis. So even in stage 4A disease, 4B disease, that is inguinal lymph nodes, we do have a radical intent. We treat patients even with supraclavicular lymph nodes with radical intent these days. It all depends on the local disease. Like Sir said, if you have a frozen pelvis and a supraclav lymph node, I would not even think of a radical intent in this patient. If I have a patient who has a central disease, a young patient who has an ulcer proliferative disease with a nodal chain going up to a supraclavicular, I would treat the patient with radical intent. So it varies from patient to patient. Okay? So it's not an absolute contraindication. If you have an inguinal lymph node with a patient who has a lower third vaginal involvement, a frozen pelvis, and a fistula or an impending VVF, I would not treat this patient with a radical intent. The intent would be palliative. So it would depend again from patient to patient.
If I can rephrase what you're saying, you want the patient not to suffer disease in the pelvis, which is devastating during her lifetime, which may, although be limited by distant metastasis, the pelvic control immensely improves the quality of life and mitigates against untold suffering. That's the goal, one says.
Absolutely.
If I got it right.
Absolutely, sir. And this is what we argue even for endometrium. If you see the GOG 256 trial, where they said in locally advanced stage 3, stage 4 endometrial cancers, you can only give 6 cycles of chemotherapy. And, they compared it to the POTEC 3 arm, where you gave chemotherapy with radiation. They said that chemotherapy alone is comparable to radiation plus chemotherapy. But what about the pelvic control? It's the pelvic symptoms that are devastating. It is the pelvic symptoms that are bothersome. So you have to you always do not have to have evidence of, a local, I would say a disease-free survivor. You could have less of pelvic control, but you have to have control of symptoms. That is also very essential when dealing with advanced tumors.
Exactly. Quality of life is more important.
That is where comes the role of pelvic radiation. In fact, there has been a trial published in the JAMA a couple of years ago, I think maybe in 2019 or so, which clearly showed that there is a benefit of there is a survival benefit of adding pelvic radiation in patients with advanced metastatic disease in cervical cancer. So radiation definitely has a role to play. And I think there is no way we should let the medical oncologist or other make us believe that it's the chemotherapy that has to be given in advanced disease. Give your radiation first and then talk about the chemo later.
Ma'am, one question I think you should cover in next lecture. In brachytherapy, how we decide ideal packing has been done?
Ideal packing. Okay.
We can take in the next lecture.
It will be covered in the last lecture, I think.
Ma'am, I think our next lecture will be Dr. Bhavana, and it will be on brachytherapy.
On Monday.
On Monday.
Yeah.
On Monday, yeah. On Monday.
It was, I didn't think we would be able to do justice combining both external radiation and brachy in one class.
I have one question. Can I ask? Yeah.
Sure.
Actually, whenever you are planning for the hemostatic artery and you are presuming that patient, you will plan for the further radical Artito, how you titrate the dose and what are your quotas? It will be the same as radical, or you will give the concise field and you just.
See, if I'm giving it purely for hemostatic purposes, I really do not need to go up to the aortic bifurcation and irradiate a whole lot of pelvis and bowel in there, It's the local disease that you have to control and the bleeding from the local disease. So I would give a small pelvic field, including only the true pelvis. And we seldom give hemostatic brachytherapy for advanced disease. I mean, we haven't ever, actually.
Actually, her question was, Bhavna, was that if you've given 10 gray, say, for instance, either in 2 or 3 fractions or single fraction or whatever, how do you add it up with the rest of the pelvic dose in case because once that is done, you go on to give the full dose radiotherapy. So the question really is if you're using hyperfractionated plus, if you used a hyperfractionated regime or, and yes, is that right? Is that what you wanted to know, Dr. Surbi?
Yes.
Please. Then we just do the EQD2 calculations, and generally we do not do, there are patients who are, we do not do a gap correction if the patient has, is going to receive the treatment maybe after 2 to 3 weeks gap. So we prefer not to give a gap correction because, you could land up with a lot of toxicity in the long run. Again, having said that, there are very few patients in our setup who have gone to receive a radical dose of radiation after hemostatic radiotherapy, because these days we manage bleeding by other methods rather than giving hemostatic radiation.
Okay.
There is no more question.
Ma'am, questions are so many. I mean, now, actually, Dr. Sajal Goel is there. Dr. Sajal Goel is senior consultant, and he has asked your experience in those who defaulted brachy.
Sorry, I can't read the question. Your experience in those
who defaulted brachy.
Okay. Those
defaulted.
Honestly, Dr. Sajal, I don't spare any opportunity of giving brachytherapy. I've given patient brachytherapy even after 6 months of receiving external radiation if the patient was suitable. Why leave that opportunity? So although evidence does not support it, or there is no evidence in favor of that, they say the treatment should be complete within 7 to 8 weeks, but that is practically impossible in our setup. We have patients being referred from outside, we have long waiting lists. And so if the patient is suitable for brachytherapy, I would still give brachytherapy. If the patient comes after a long time and has a disease which is not amenable to brachytherapy, then the intent becomes palliative. Then I would only give treatment if there are symptoms, that is, I would give external radiation.
Okay, ma'am. Again, extended field RT, modern day indications of this.
Extended field RT. So modern day indication now is para-aortic lymph nodes. There is upcoming role of extended field, prophylactic extended field radiation, and that is coming up in the Embrace 2 data, which is being analyzed. But as of today, if you talk about evidence, it should be done. There isn't any evidence of practicing it routinely. It should be only and only done in a trial setting. And the patients in whom you may practice extended field or would qualify later, perhaps for extended field, would be patients who have lymph node metastasis, maybe more than 3 lymph node metastasis, or a lymph node at the common iliac region, where you have to go 1 echelon above and include the para-aortics. But as of today, you just take your superior border of the fields. You go by the basic principles of external radiation, that you go 1 echelon above for nodal disease. And so the indication remains only para-aortic lymph node involvement.
Okay, ma'am. So what we should remember, I think we should complete the whole treatment within 8 weeks, 7 or 8 weeks. And
7 weeks is what this is, but 50 days to be precise, but it's usually not possible.
And what I request, ma'am, our students who do not practice brachytherapy, please practice it. And you can come in any, I think, our institute and see how it is being done. That is very important. And over to you.
Absolutely essential, sir. I don't think we should give the MD degree if they don't do brachy.
Yeah. Ma'am, and what I think the parent institute actually can provide some opportunity to them.
Yes, we should be sending students. There should be some form of exchange program, or we should be sending students to institutes where brachytherapy is done, but we just cannot do without brachytherapy training. That is absolutely essential.
Yeah. So thank you so much, ma'am.
So I think I have missed 2 or 3. So I request Dr. Shalin sir and Sylvie ma'am to please give final remarks.
Dr. Shalin sir.
Thank you very much, Bhavna. That was stunning to say the least. It was enthralling, and I really feel it was silly on my part. I should have joined you earlier to get the full range of experience, and fun and revision. Fantastic, really. Looking forward to your next presentation. And so I think Dr. Sulbi would have shared a little bit of an outline of these things with you. She might have.
About yes, she did.
Yeah,
About the range of things. Yeah.
So thank you so much, Dr. Bhavana, for such a wonderful lecture. I think this is one of the most discussed here, this lecture. We have so much questions here, and you answered. I know, we will cover next lecture because time limit is there, but it was really very wonderful lecture, and we are very lucky to have you in for our another lecture, which is going to be scheduled on Monday. Content I have already shared, Dr. Bhavana, with you. I will resend.
Yes, you've done that.
Yeah. So thank you so much, Salin sir. Thank you so much, Dr. Bhavana, once again. Thank you, Dr. Rashi. Thank you all the participants, and good night, everyone. Thank you.
Thank you, Dr. Shalin, Dr. Rashi, and Dr. Sulbi.
Good night.
Thank you very
Yes,
much.
lovely.